Good morning. As we are surgeons, we have been managing complications of our anterior segment colleagues. But when it comes to your own uh, problem, it is difficult to keep cool. I'll be starting my presentation with a nightmare situation that happened at my own center about 3 months back. 8 patients for various injections were injected anti-VEGF agents. 7 were injected plain Avastin and 1 with triamcinolone. Next morning, the patient complained of blurring of vision just 24 hours after the injection in seven eyes. On examination, there was no lid edema, there was no congestion, and no pain in all the patients. There was mild corneal edema. There were varying grades of AC reaction, ranging up to hypopion. There was fibrinous reaction in the pupillary area. Reaction in the vitreous was very minimal, and ultrasound was almost normal. There was no abnormal reflectivity. Intraocular pressure was also normal. So the first thing came to my mind whether it is infective or sterile. There was one interesting finding that the eye injected with triamcinolone was quiet. There was no reaction in that eye. Another thing that all the patients showed microbiological examination was negative, that there was no infective pathogen found on microbiological examination. Seeing this situation, I assumed that this is sterile endophthalmitis, but out of the fear and because of some overlapping of the symptoms, I injected intravitreal antibiotics in 3 patients. And all the patients were started on frequent topical steroids. All these patients started showing response in 24 to 48 hours after the treatment. There was decrease in AC reaction. There was contraction of fibrin, which is a very early sign of improvement in endophthalmitis, and also the improvement with vision. There was significant improvement in a week's time in all the patients. So this nightmare situation was resolved, but it helped me in understanding this problem much more deeply, and I would like to share this in very simplified terms. Intravitreal injections have become the second most common procedure in ophthalmology after cataract surgery, and so is post-injection endophthalmitis. This is actually sterile endophthalmitis or non-infectious inflammatory endophthalmitis, which clinically mimics infectious endophthalmitis, and it presents very early after the procedure, usually 12 to 48 hours after the injection. It may be a reaction to preservative, vehicle, or the drug itself. Now, coming to infective endophthalmitis, you can divide it into 3: acute, delayed, and late post-operative endophthalmitis. And based on these 3 things, the clinical presentation also varies, and so is the treatment of these situations. Acute post-operative endophthalmitis presents slightly late if you compare it with sterile endophthalmitis. It usually presents within 2 to 11 days following the procedure. It is usually 70% of the patients are associated with pain and decreased vision. On examination, there will be lid edema, conjunctival injection, conjunctival congestion, and in some cases, corneal edema. Here, the corneal edema will not be diffuse. There will be varying grades of the intraocular inflammation, maybe severe flare, cells leading up to hypopion. In post-operative endophthalmitis, most of these patients are associated with vitritis, that is the loss of red reflex. If the anterior segment is not clear, you can assess this with ultrasound examination. If the media is clear, these patients are associated with retinal infiltrates, hemorrhages, and periphlebitis can be seen in these patients. Acute is mostly associated with gram-positive organism, and the coagulase negative with Staphylococcus and Staphylococcus aureus are the most common organisms. These acute endophthalmitis occurs mostly in patients who have had prolonged surgery, maybe because of the posterior capsular rent or vitreous prolapse. Now, the delayed onset endophthalmitis is characterized by the insidious chronic inflammation developing weeks to months following surgery. There will be low-grade anti-chamber cellular reaction. There will be KPs, anterior and the anterior vitreous cells. Hypopyon and pain here is relatively uncommon. Some of the patients will have white capsular plaque, and this is actually the encapsulated organism within the capsule. And this condition sometimes masquerades or mimics chronic non-infectious uveitis because it responds initially to the topical steroids or oral steroids also, but when you taper off these steroids, it recurs again. So it masquerades as chronic non-infectious uveitis. These organisms, they enter at the time of surgery, but these organisms are less virulent than those causing acute endophthalmitis, so the endophthalmitis develops later. Now, the late postoperative endophthalmitis is most commonly seen in patients with glaucoma filtering surgeries and patients who have had some wound abnormalities. It starts as blebitis, which is easier to treat, but when the organism goes inside the intraocularly, it develops into endophthalmitis. Clinically, the features of late postoperative endophthalmitis is same as an acute endophthalmitis, and it is seen commonly in patients who have thin blebs, cystic blebs, and where the mitomycin has been used. In late also, the organisms gain access into eye after the surgery or immediately after the post-operative period, or it may also gain access later in the later course through the thin filtering bleb. Prognosis in this situation, if it develops into endophthalmitis, is really poor. Now, coming to the toxic anterior segment syndrome, it is actually like sterile endophthalmitis, but this occurs in setting of anterior segment surgery. The hallmark of TAS is an inflammatory reaction in the anterior segment that starts within 12 to 48 hours after the surgery. This is very important. There will be diffuse limbal to limbal corneal edema. There will be varying grades of inflammation in AC, ranging up to hypopyon. In TAS, there will be minimal or no vitreous reaction. These patients may have dilated pupil and iris pattern abnormality because of the iris involvement. There will be damage to the trabecular meshwork that may lead to secondary glaucoma. If the media is clear, you may see cystoid macular edema. And the important thing here is that this TAS improves if treated frequently with the topical steroids. Just because something is sterile, it does not mean it is non-toxic. The material that enters the eye will present as various grades of toxic reaction. It may be mild, moderate, or severe. Now, to sum up, how to differentiate between TAS and the infectious endophthalmitis. TAS usually presents within 12 to 24 hours after the procedure, and infectious develops 2 to 7 days after the procedure. TAS is usually not associated with pain, and infectious variety is almost in 70% of the cases is associated with pain. There will be diffuse limbal to limbal corneal edema in TAS, whereas in infectious the edema will be localized if it is there. IOP will be increased in TAS, but IOP usually is normal in infectious variety. There will be AC inflammation in both the situations. You don't see vitritis or vitreous inflammation or vitreous reaction in TAS cases, whereas in infectious, the vitritis is almost always present. Visual acuity may be decreased in both the situation, and TAS responds dramatically to steroids. Vitritis is common and infective, and this can be very easily assessed with the ultrasound examination. There are two more situations which can be confused, which can be difficult to differentiate with in endophthalmitis is one is lens-induced uveitis and anterior uveitis with keratitis. Microbiological diagnosis is also not always helpful. So in the end, I would say that signs of all these conditions may be overlapping. If you are not supported by microbiological diagnosis and if there is any confusion, treat these patients as infective in case of any confusion. Thank you.